If you're a dentist who's had problems anesthetizing mandibular teeth, then this video is for you. If you're new to the channel, my name is Siju Jacob. I've been a private practitioner in Bangalore and Dubai for the past 25 years. In addition to private practice, I've been teaching dentists how to use the surgical microscope in everyday clinical practice for more than a decade. Let me know if this sounds familiar to you. You have a patient scheduled for endodontic therapy of the mandibular first molar. The patient walks in, you administer an inferior alveolar nerve block, and then you start working on the tooth. The minute the bird touches the tooth, the patient literally jumps off the chair. The tooth just doesn't get numb no matter what you do. In this video, I'll talk about all the things that you can do to drastically improve your success rate in anesthetizing mandibular teeth. Let's take a look. By the way, I've put together a short PDF that summarizes all the techniques that you can use in your private practice to anesthetize mandibular teeth. You can download it for free. I've put the link in the description below. Do have a look. It's right down below. Let's look at all the techniques that you can follow in everyday clinical practice to dramatically increase the success rate of mandibular anesthesia. Let's start with something that you can do even before the patient lands up in your clinic. The first step that you can follow is to administer non-steroidal anti-inflammatory drugs even before the patient lands up for the treatment. Anesthetics works best when there is reduced inflammation in the tissues. And one of the best ways to lower the inflammation in the tissues is to prescribe non-steroidal anti-inflammatory drugs, which the patient can take a couple of hours before the procedure. Simple tablets like an ibuprofen 2 hours before the procedure can dramatically lower the inflammation in the tissues and dramatically increase the chances of mandibular molar anesthesia. So this is something that you can follow even before the patient walks in for the procedure. So that's step number one. The second thing you can do is to increase the volume of anesthesia that you administer for an inferior alveolar nerve block. Most dentists tend to underdose when it comes to local anesthetic solutions. We have been taught from dental school to administer one carpule or one cartridge of local anesthetic, which is typically about 1.8 ml, and it's often not enough to completely soak the nerve trunk when you administer an inferior alveolar nerve block. So it's always a good habit to double the dose. Instead of one cartridge, give 2 cartridges. The local anesthetics that we use in everyday clinical practice have a very high degree of safety margin, so you can very, very safely give 2 or sometimes even 3 carpules without any side effects. Most practitioners tend to ignore this. They give just 1 carpule and you might get some numbness, but the numbness is not deep enough to perform procedures like endodontic therapy or even deep restorations. So one of the first things you can do is, instead of giving just 1.8 ml for a block, we can double this and give 2 carpules as a standard protocol. This will dramatically increase the chances of anesthetic solution deposited into the tissues being significant enough to coat the nerve trunk and have enough efficiency so that the tooth becomes numb. So that's the second step you can use to increase the chances of mandibular anesthesia. The third technique you can use is to aim higher. Most clinicians, when they administer an inferior alveolar nerve block, they tend to go lower than the mandibular foramen. So it's always a good idea to aim higher than lower, because when you are in some sort of an error, once you go lower than the mandibular foramen, then it's almost impossible to soak the nerve. Whereas if you aim higher, then you have a chance for the anesthetic to diffuse into the inferior alveolar canal before the nerve enters the canal. So aiming higher is always better rather than aiming lower. And one of the things you can do to ensure that it's high enough is to make sure the patient opens the mouth wide enough and then look at the landmarks and correct for some sort of an error. But when you do this correction, it's always better to aim high rather than aim low, so that even if you make some sort of an error, you will still be above the mandibular foramen. So that's the third technique you can use. Aim a little higher than what you think is the adequate height for depositing the anesthetic solution, so that even if you go marginally wrong, the anesthetic solution can still diffuse from a higher to a lower level into the inferior alveolar canal. That's the third technique that you can use. The fourth technique that you can use to increase your chances of effective anesthesia in mandibular teeth is to wait enough time after administering the block. Most practitioners do not give adequate time for the anesthesia to start working. They start way too early, and as a result, they start working way before the tooth becomes completely numb. So a good rule of thumb is to anesthetize, give the inferior alveolar nerve block, and then wait at least 15 minutes before starting any procedure. Most practitioners start working 2 to 5 minutes after they administer the inferior alveolar nerve block. Unfortunately, this is just not enough time for profound anesthesia in the majority of cases. This, according to me, is the single most important thing that a majority of practitioners neglect, and they start working way too early, and it's just not enough time for the tooth to become completely numb. And the simplest thing to do is wait enough time before you start working. If you have a very busy practice and you do not want to give anesthesia and then make the patient wait on the chair without doing anything for 20 minutes, then you could probably change your protocols. You could make it a practice that whenever you are anticipating a procedure on the mandibular teeth, you could administer anesthesia and then make the patient wait in the reception for some time, maybe 25 minutes, and then start working. This will ensure that you give enough time for onset of anesthesia before you start working on the tooth. The majority of practitioners overlook this fact, and this is one of the main reasons why the tooth just doesn't get numb, because practitioners aren't giving enough time. So that's the fourth step that you can follow in your private practice to increase the odds of effective mandibular anesthesia. Wait longer. The fifth step that you can follow is to always supplement with buccal and lingual infiltrations after a block. So we give 2 carpules as inferior alveolar nerve block, and we just don't rely on only the block. We always supplement buccally and lingually with infiltration. What this does is it takes care of accessory innervation, which can happen via the long buccal or the mylohyoid or the lingual nerves, and infiltration buccally and lingually will take care of these accessory innervations, thereby increasing the chances of mandibular anesthesia. The sixth step that you can follow to enhance mandibular molar anesthesia is to use articaine instead of lignocaine. Now, this could be purely anecdotal, but I have found in my own experience that when I shifted to articaine from lignocaine about 20 years ago, I found that it was way more effective than infiltration with lignocaine. I don't know how it's in your practice, but this is my experience, and it is one of the best things you can do. Switch over from lignocaine to articaine for lingual and buccal infiltrations in addition to the inferior alveolar block. This single step can dramatically increase the efficacy of mandibular anesthesia. If you followed all the steps that we discussed just now, then the chances of you not achieving pulpal anesthesia are extremely low. However, there are some rare cases where despite you following all the techniques, you have a situation where the patient is completely numb. Profound lip numbness, tongue numbness, and the tissues are completely numb, and you verify this by exerting some pressure with some sort of a sharp instrument, and the patient seems to be completely numb. But the minute you start working, you find that the pulp is not 100% numb. Then those teeth might require some other forms of supplemental anesthesia. The most commonly employed supplemental techniques are periodontal ligament injections and intraosseous injections. Periodontal ligament injections are very common, and there are a variety of devices that you can buy and keep it in your practice. These are pretty useful for restorative work as well as a supplemental technique just before you perform your endodontic access or any procedure which is really close to the pulp. We can administer periodontal ligament injections as a supplemental technique. Intraosseous anesthesia is the other very effective technique which you can use in everyday practice. There are different systems for intraosseous anesthesia. In the past, we had something called Stebidin system, and then we had some modifications of that. And these days, you have another system called Quick Sleeper, I think. So there are various techniques available these days, which makes it very easy to administer intraosseous anesthesia. And it is an extremely useful technique to have in your armamentarium in those cases where traditional techniques don't seem to work 100%. So intraosseous anesthesia is probably the last resort. And I haven't seen many cases where after you give a block and infiltration and supplement it with intraosseous anesthesia, the tooth is still not numb. I have never seen it in my own experience. So that is probably the last thing that you need to employ, intraosseous anesthesia. Let's say you've practiced all these things and you find one particular spot in the pulp which just doesn't get numb. This is probably seen in some teeth which are undergoing that stage or that transition from irreversible pulpitis into necrosis. So you find that tiny bit of pulp tissue which just doesn't get numb no matter what you do, then you probably employ intrapulpal anesthesia. What you have to understand is that when you give intrapulpal anesthesia, you want to give it under pressure. It doesn't work if the needle is loose in the pulp chamber or in the canal. You have to jam the needle into the pulp chamber or the root in such a way that there is some sort of a tightness and it creates a piston effect, and then you inject under pressure. If you aren't able to generate that pressure, some resistance to injection, then the intrapulpal anesthesia doesn't work. But if you manage to get enough pressure and you inject under pressure, then it works 100% of the time. The only problem with intrapulpal anesthesia is that it is traumatic, so it is very painful for the patient. So one shouldn't use it as a primary supplemental technique. One should only employ it in those cases where all other techniques have failed, and that too just for a brief period, just to help you accomplish a certain stage in your procedure, not for a long period of time. So in a nutshell, these are some of the techniques that you can use to dramatically increase the efficacy of mandibular anesthesia in your everyday clinical practice. Like I mentioned, I've put together a short PDF which summarizes all these techniques in detail, which you can download for free. I've put the link in the description below. You can use it, take a printout, keep it in your clinic, and use it as ready reference. Do check out the link in the description below. If you enjoyed the video, don't forget to click on that subscribe button so that you get notified every time I upload a new video, which is usually every Sunday. And if you'd like to watch more endodontic videos, do check out some of these videos that I've uploaded here on my channel. I'll see you next week with another video. Till then, take care. Thanks for watching.